মূল ডিপার্টমেন্টের মানুষ সব যেহেতু
Yes, thank you. Good afternoon, everyone. I am Shamanto Das from Guwahati. As you know, today we are having an online training on stress management relating to COVID-19 pandemic, and I will be speaking on the psychiatric aspects. In fact, I am happy to be here as well as honored because psychiatry has been the Cinderella in medical science, or Ohomia Tezimola, always at the receiving end of stepmotherly attitude. But today it has come to the forefront in our fight in this pandemic. In fact, if we go to history, we can see that psychiatry came into prominence during the World Wars. There were many disorders which were diagnosable during that time, but the armed forces also suffered from disabilities which does not fall into any categories of disorder, but at the same time there were impairments. Then entered psychiatry in the scenario to diagnose those conditions which were causing disabilities which cannot be put under any other medical diagnosis. Today we come to such a scenario, post-World War II, never occurred before kind of situation, and here we mental health representing psychiatry are again in the forefront. The COVID-19 outbreak has been declared as a pandemic by WHO on 11 March. Over 1 million people are infected and more than 50,000 deaths are reported worldwide. And this statistics is changing every day, every hour, every minute. Following a pandemic, there is profound and broad spectrum of psychological impact that can be inflicted on people. At the individual level, it can precipitate new psychiatric symptoms in people without any mental illness earlier. They can aggravate the condition of those with pre-existing mental illness and cause distress to the caregivers of fatal individuals, including healthcare workers. People may experience fear and anxiety of falling sick or dying helplessly, or blame others who are ill, potentially triggering a mental breakdown. Psychiatric morbidity have been found to vary from depression, anxiety, panic, somatic symptoms, post-traumatic stress disorder, to delirium, psychosis, or even suicidality. The inability to gain closure can result in anger and resentment. Those who are sick and are quarantined, they may experience same guilt and stigma. Longer duration of quarantine is associated with increased prevalence of PTSD and depression. There could be distrust towards other individuals in terms of disease spread. With the closure of community services, negatively impacting the economy, many people end up with financial losses, further intensifying the negative emotions like hatred, anger, and hostility. Stigma and blame targeted at communities affected by the outbreak by other countries due to fear of infection, fueling further unrest. There is increased rumination of contacting the disease. This can profoundly remodel people's behavior and social interaction. Feeling of helplessness when in anxiety can often motivate people to use unproven methods and remedies that can be detrimental, like substance use behavior. We, the doctors, sisters, including paramedics and ambulance personnel, have also been found to display heightened stress, become emotionally affected, panicky, traumatized, and are vulnerable to develop depression and anxiety. This is expected as the anxiety and fear of getting infected is much higher than the risk of exposure. There may also be a fear of transmission to their loved ones and children. The balance between professional duty, altruism, and personal care for oneself and others can often cause conflict and dissonance in many healthcare providers. They are more vulnerable to develop PTSD as they are directly exposed to loss of so many lives. So the need of the hour, most of the countries have focused on controlling the disease curve without much lower attention on mental health. For a change, we are having a standard operating procedure where mental health is given equal importance, which is considered as a pivotal role in the process of recovery. So a multidisciplinary mental health scheme is necessary to carve down the consequences of the pandemic. The team should comprise of psychiatrists, clinical psychologist, psychiatric social worker, and a counselor, including community nurses. It ranges from psychiatric clinics in all hospitals, private psychiatry and psychotherapy clinics, and friendly counseling centers in the community. Regarding the support for frontline health workers, it is important to safeguard the moral and mental health of healthcare providers, as this can increase the success of healthcare delivery. PPs are the #1 priority. The organization may consider shorter working hours, regular rest periods, and rotating shifts for those who are working in high-risk areas, including quarantine time. Support from colleagues, supervisors, and the care communication of directive and precautionary measures can help reduce psychiatric symptoms. Confidence in infection control measures may mitigate and facilitate an adaptive stress. That are we going to get contaminated? Are we going to suffer? This is a kind of threat stress, which leads to anxiety spectrum symptoms. On the other hand, if we perceive the stress as a loss, the fear or the loss of someone near and dear ones, or even may die, or even patients losing their lives, can lead to symptoms of the depressive spectrum. Whether it is anxiety spectrum or the depressive spectrum, both these emotional responses we don't cherish. As a result, there will be an effort to overcome these symptoms. When we make a conscious effort, we call it coping. And when there is an unconscious way to overcome these emotional responses, it is the defense. Coping strategies, while applying them, we are aware, we are conscious. And they can be either problem-solving strategies or emotion-reducing strategies. Usually can be used to make adverse circumstances less stressful, while the emotion-reducing strategies alter the response to the stressors. If we look to certain problem-solving, they can be obtaining information or advice that would help solve the problem. At times, we may require confrontation, defending one's rights and persuading other people to change their behavior, or solving the problem, that is, making and implementing plans to deal with the problems. About emotion-reducing strategies, ventilation of emotion is a way, talking to another person or expressing our emotions. We can evaluate the problem to assess what can be changed and try to change it by problem solving, and to accept what we cannot change. Avoidance can be another way of the problem by refusing to think about it, avoiding people who are causing it, or avoiding reminders of it. Finally, positive reappraisal of the problem is another way of emotion reducing strategy. Here, one recognizes that it has led to some good. For example, the loss of a job is an opportunity to doing a more satisfying occupation. Now coming to the unconscious mechanism of defense to overcome the emotional responses. Here it is important to highlight that defense mechanisms are unconscious process. That is, people do not use them deliberately and are unaware of their own real motives, although they may become aware late through introspection or through another person's comments. By looking closely to our own behavior and giving an active listening what others have to say about our behavior, we can gradually understand how we use defense mechanisms, and with gradual practice, we can make it a habit. In response to stressful circumstances, we use different types of defense. There are some immature, there are some neurotic defenses, but what we need to concentrate upon is the mature defenses. Like sublimation, anticipation, humor, altruism. As we say that in psychiatry, all of the chapters of the textbook are for patients, but this is the chapter for self. There are different maladaptive coping strategies. I will not be going into the maladaptive ones in detail, but one thing that is very relevant here is the substance use behavior, including alcohol, which is definitely a maladaptive coping strategy. Yes. Yes. Yeah, I'm listening. Pardon? Okay.
Network problem is it?
Yeah, Rata is trying to look after the matter. Morally funny to dia now. Twenty minutes we say. When I 40 look question can you learn?
सिस्टम तो सेंड दे रहा है, फेल टू स्पीकर आ रहा है लैपटॉप में। यार मुझे वाले एमएस वाले में हाँ यार फिर वो चीज मैंने ग्रुप में डाला था, सीधी से कभी भी हो जाता है ऐसा जूम में। मैंने अच्छा मैं जूम से हट रहा हूँ, ठीक है चल जूम से मैं जूम बंद कर रहा हूँ फिर। नहीं ना रिकॉर्डिंग मेरे लैपटॉप में हो रही है, क्लाउड में क्लाउड में थी, क्षितिज ने क्लाउड से बंद कर दी, फिर मेरे लैपटॉप में हो गया।
सर এবার বন্ধ করে দিও নিছে গতিটো।
ৰবাচোন মই অখিলেশৰ লগত কথা পাতি লওঁ, তোমাৰটো বন্ধ কৰাচোন। অখিলেশ हेलो, ये क्या हुआ? कुछ प्रॉब्लम है लाइव में? राभा स्टार्ट কৰিব পাৰিব? ৰেডি হ'ব কোৱা।
স্টার্ট কৰিব পাৰিবনে আৰু দুবাৰ?
পাৰিব, অলপ 2 মিনিট ৰেডি হ'ব কোৱা ডক্টৰক।
ঠিক আছে, আছে ওচৰতে আছে।
Share